and KMC in the field of quality and sometimes in laboratory medicine and biochemistry also. So, when I receive this topic, thus beyond the basic, the role of advance in lipid testing in modern medicine. I think, I think this is the topmost priority post COVID in laboratory medicine. Why? When WHO checks post COVID, this is the really problem in our community is non-communicable disease, and in this field is around 50% death in non-communicable disease contributes the cardiovascular diseases. And just like astrology or like that, predictive particle is lipid molecule, not lipid profile test. And an interesting part is nowadays in first world country, not required lipid profile in general population, required when cardiac problem and postmenopausal women and family history positive. So, this is a good picture. This picture, all are familiar with this picture. In these areas, we are not bargaining, but they are adding calories constantly. This calorie is our burden. This is a beautiful ISO 15189 standard laboratory reports, two different laboratories report. One is from ISO 1, you just check first report, LDL methodologies are there, but when you multiply by VLDL by 5, then you collect this data is HDL cholesterol. And next report, same report, they are using the methodology as per 15189 standard. In India currently says the NABL standard or something, and tomorrow again NABL rally in Jamshedpur. They are giving VLDL cholesterol result just when you multiply by 5, VLDL is not equivalent to triglyceride. So, one is calculated LDL, another one is direct LDL estimation. Because somebody using this estimation in some formula is called Fredwell formula, all over this country initially using, and subsequently in this field we are getting the direct LDL measurement, though that time we are not measuring the LDL cholesterol in that way. So, so many methods are available, and this LDL cholesterol measurement is not applicable for diabetic patient, hyperlipidemia, and when cholesterol is more than 400 milligram per deciliter. So, everybody knows all these issues. Now, after this more than 400, when more than 400 cholesterol level, then we are checking in website and other field, even in textbook, so many equations, Ananda-Raja's equation, Sampson's equation, Martin-Hopkins equation, and Pauwelli's equation. And in Pauwelli's equation is divided instead of 5, instead of 6, after that Backward's equation is 6.5, after that Backward's corrected version is 6.3. Somebody is giving different equation. Then National Cholesterol Education Program Adult Treatment Panel 3, American College of Cardiology, American Heart Association guideline assessing individual cardiac risk as the framing the heart risk score, FRS score. So, this score is basically a data sheet, is based on age, sex, blood pressure, diabetes, smoking history, and obviously in cholesterol and subclasses measurement. This is the prediction for another 6 years myocardial infarction or cardiac risk. For 6% is prediction for 10 years for low risk, and 6 to 20% is high moderate risk, and after that high risk is more than 20%. These data sheets are available in website, and you can collect these data, or you can calculator is available in different calculators are available. You can calculate this, just put this data, and then what is the advice for that? After this advice, if our score is high, then you to check your lipid evaluation. Lipid evaluation, not lipid profile test. Why lipid evaluation is required? Lipid evaluation is required in one single data as per Harrison is less than LDL cholesterol is value should be less than 100, and again is optimal goal will be less than 70 milligram per deciliter, and lipid lowering agent you have to use for the primary production of your therapy. And this is the beautiful model before going to modern testing method. Modern testing is mostly based on the AI technology, and without AI technology no instrumentations are available for modern techniques in the field of laboratory medicine. And this is the specialist, just like you are the future clinician or gynecologist or surgeon or cardiothoracic surgeon, your requirement in future, this is the for clinical consideration and ethical consideration. So, here if you check this first 3 points in chylomicron, VLDL and VLDL remnants, these molecules are the molecules based on the triglyceride based molecule, and after that is the ideal cholesterol particle size and LDL cholesterol with lipoprotein A is where is lipoprotein is the genetic marker, and lipoproteins contains more dense and small dense LDL. Initially we are thinking this LDL cholesterol, now we are coming in the picture is the dense cholesterol and small dense cholesterol, and after that again in HDL is a good cholesterol, we are in here is also a fraction for HDL2 and 3, whereas the HDL2 is better marker for your lipid. In this world, in the field of laboratory medicine, these 3 methods are the popular methods in lipid testing. One is vertical spin density gradient ultracentrifugation, second one is NMR technology, nuclear magnetic resonance technology, and third one is segment and density gel electrophoresis. Till date, segment and gradient gel electrophoresis gives a wonderful result for all these particles, all these lipid particles detection, whereas in NMR technology can't give the LPA as value, because LPA and LDL is same structure. So, if we check this picture, still enema technology is the best possible technology where some particles we are not counting, because this is just similar to the popular MRI technology, because its nuclei is oscillated and generates some peak. This peak is the marker for individual lipid particles. So, in those the future researcher in the field of medicine or biochemistry is the option for lipid this NMR technology in future for lipid analysis and subclasses. This picture already you know this because of in your curriculum you finish your structure with LDL cholesterol structure, all knows, and here is two things is lipoprotein B100 is around 20 to 22%, and cholesterol ester is around 42%, and triglyceride is only 6% in this structure. And these photographs is two photographs is one is LDL particles photographs and another LDL cholesterol photographs. And now you have to check this two part because of why LDLs, small LDLs is very important in your atherogenic plaque. Number one is more small, so when large molecule particle contains cholesterol, then 70% more cholesterol, more particle size in small lipoprotein cholesterol. So, small lipoprotein is more particle size compared to LDL, and sometimes is again in same size and 40% more particles in small dense LDL. In this is not measurement done by our conventional methodology. This is the interesting place where VLDL triglyceride reach in liver, then transport protein convert to the HDL cholesterol, and HDL cholesterol is smaller size released to the kidney, and in cholesterol ester is transport protein. In other hand, an exchange program is doing LDL cholesterol. In hepatic lipase is lipolysis contains small dense LDL. This small dense LDL, number one, you release this small HDL in our through our urine, and so HDL will be the lower in our system and small dense LDL will be the higher in our system. So, this mechanism is very important for the how to identify this particle and where is the problem, you have to check for that. In atorvastatin, sometimes in atorvastatin is the only option for lipid lowering in that place, and sometimes you can use niacin and other medicine also. So, in all these apolipoprotein B, now we are coming for the all these small particle in lipid particles is the better marker for atherogenic risk, and this atherogenic lipoprotein LDL, VLDL, IDL, intermediate density lipoprotein and LPA contains one apolipoprotein protein B. This is ApoB100. You have to check in the first slide the LDL molecule, and high ApoB indicates high number of small and dense LDL cholesterol. So, when you endothelial dysfunction, inflammation and ApoB is the condition for your atherosclerosis. Again, in lipoprotein A, in this red color we mentioned in standard cholesterol can't estimate the LDL cholesterol, they estimate both LDL and IDL particle. That is why the modern estimation is required, and LPA contains ApoB molecule, cholesterol rich with a lipid core. But another thing is LPA is influenced because of this genetic influence and genetic influence, just like LPA in higher in blacks and Asian compared to Asian and white white patients. So, compared to black we are safe, but it's a genetic marker. We can use the LPA in genetic marker in AI technology also, gene analysis. Just like in BRCA1-2 gene we are analyzing, same way we can analyze the LPAN and the early marker for the LPA atherosclerosis or cardiac risk. Again, another part in first second slide, it was just triglyceride rich remnant lipoproteins. When triglyceride values was more than 100 and when triglyceride were less than 100 and triglyceride values are more than 200, that is a different picture, different equation. Because in liver you know the liver is the main reaction site in our body, because of triglyceride in liver with the help of lipoprotein lipase is a smaller VLDL molecule to convert the intermediate density lipoprotein called lipoprotein, and then again in hydrolysis formation of larger LDL. So, if less than 100, then you may produce the bigger molecule for LDL. When triglyceride values are less than more than 200, then larger VLDL and triglyceride reach to formation of remnants in same mechanism, where smaller VLDL and IDL is prepared, and again in hepatic lipase with lipolysis with triglyceride and cholesterol esterase transfer protein form smaller LDL. This smaller LDL is the main source for your plaque in artery. So, this deposition is possible. So, why we are planning for less than 200 triglyceride and more than 200 triglyceride in normal lipid pattern. So, more than 200 triglyceride, some reaction is something different, then again you have a problem for that. And in high triglyceride is again is a risk factor for cardiac heart disease and lipid abnormalities is in this type of lipid, mostly in type 2 diabetes, and this remnant lipoproteins and lipid related risk factor, this is the marker for NCEP ATP3 guidelines. So, high levels of triglycerides lead to a large value of VLDL particles. Again in that picture we shared you the HDL subclasses, where HDL2 and 3, HDL2 is the larger particle and HDL3 is the smaller particle. HDL2 is more protective in HDL subclasses, and higher levels of HDL2 associated with atherosclerosis progression and lower risk less atherosclerosis progression and lower risk for cardiovascular diseases. In this case, niacin is most effective drugs for the increasing level of HDL cholesterol. So, sometimes we are using statin, atorvastatin, and sometimes we are using some vitamin is niacin. So, again if you are familiar with this particle size, then you can finalize what medicine you have to apply for this patient. And in future direction is again is the monoclonal antibody. This monoclonal antibody is the PCSK9 is applicable for treatment. Now, from this structure, we are finalize this as per National Cholesterol Education Program 3. This is a lipid risk factors is small dense LDL cholesterol, lipoprotein A, remnant lipoprotein and low HDL, and moderate risk is more than 130 milligram per deciliter for LDL cholesterol, and optional is optimal is less than 100, and better market is less than 70 milligram per deciliter is for LDL cholesterol pattern. Now, we are coming to the picture, because all this particle, all this chemistry you are familiar with in your curriculum and finalize the curriculum. Now, we are coming to the case studies, because this case studies is the then you can understand the what is the prescription and what is the treatment and what is the what are the follow up for that patient. Patient with unexplained premature coronary heart disease. Is a patient profile is 42 years male, no history of hypertension, diabetes, dyslipidemia and smoking, family history, no family history for cardiovascular diseases, lifestyle is physically active, balanced diet, moderate alcohol consumption. And starts symptom, discomfort in chest pain in last 3 months, and palpitation sometimes. This is the symptoms, and probably this is the family history we miss sometimes. This the LPA level will be high. So, then blood pressure was normal, heart rate normal, lipid profile all are normal, only problem is LPA elevation. So, and this mutation PCSK9 mutation, this molecular mutation is the threat for this patient. Next interesting case is strong family history of coronary heart diseases, just occasional chest tightness during exercise, some and this is young, so he is going to the gym or something, that time some issues, then and then you check the family history. What is the family history? Family history, MI in his father is 45 years, uncle's bypass in at the age of 50, and diabetes and smoking history is not available in this family. So, when you check this lipid profile for this patient is high LDL cholesterol, HDL are low, and triglyceride is borderline. In that case, this lipid LDL is the culprit for that. And again in ApoB, ApoB is the another more than 30 milligram per deciliter is high. This is 110 is elevated, and LP is also 95 is another high risk. And in high sensitive CRP is also high in 4.5 milligram per liter, because in more than 3 is high, and so you can predict from lipid profile the this history. And diagnosis is high risk individual due to the strong family history of premature coronary heart disease and elevated level of LPA. In both the cases is LPA level is high. So in you have to measure, instead of triglyceride, cholesterol and VLDL, LPA and other measurement to in proper way. And so from key points for that: strong family history of CHC, significant increase, elevated LPA is again you should screen, and advance is ApoB, HSCRP and LPA beyond the standard lipid profile test. You have to measure and give some ideas for changes the lifestyle, and so you have to mention that also. So, and this is cascade screening approach is patients with a family history of elevated lipoprotein A. Because of LPA's family history, when family history goes through the family history, this is a predictor and marker for the, if you have a LPA is high, then you have a chance for coronary artery disease and more small dense LDL in your body, because an LDL is connected with the LPA in structure. So number of LPA and LDL is almost equivalent, but we can't measure in NMR method. We have to use the density gradient method for this LPA analysis, because LPA and LDL both the structure are same in same peak in magnetic resonance, nuclear magnetic resonance. And here is a patient complaint is asymptomatic, but family history with heart diseases because of father diagnosed MI and stroke in the grandfather also, and his brother is also during the routine screening LP is high, and but this patient's medical history, no hypertension, diabetes and smoking history, but lifestyle is healthy lifestyle, physical activity is more than 3 days in a week, but physical examination and laboratory diagnosis in lipid profile, this is the borderline high, and HDL normal, triglyceride is also normal, but LPA is high. Again LPA is high, and the chances are plaque is high. So and HSCRP is also high. So coronary artery calcium scoring, this is another CT scan. You can check this through CT scan, the coronary plaque concentration of calcium. You can identify the score is 4, 8, 12, 30, 36 something. If more score, then more risk, and you can check from CT scan also. And genetic testing is confirmed, and through hereditary for LPA high value. Then I'm sorry, it's a small projection from, because my slide was small. So you have to check this family history first for this lipid testing. So family history screening and family history is the more important in before going for the patient's lipids testing, and LPA is the another genetic marker for this. From all these three cases, is high value is the LPA is the marker for that. And this is another issue is the only one medicine we have, the statin. So statin resistance patient. So what to do? The patients MI at for the age of family history at the father's MI is at the age of 52. Mother also diagnosed hyperlipidemia at the age of 40. This patient's medical history is hypertension but well controlled, no history of diabetes and smoking. Physically active patients. Now we check this laboratory data. Before therapy, his LDL cholesterol was 210 and high sensitive statin and cholesterol lowering there, and then changes to 170 milligram per deciliter. So and again is here also LPA level is 90 and thyroid function and creatinine kinase all are normal. So diagnosis is statin resistance hypercholesteremia and so you can treat with them with monoclonal antibody PCSK9 mutation. Now rapid unexplained progress of atherosclerosis cases is here. Patients are having chest pain, shortness of breath, and family history again is MI in 40 and hyperlipidemia, hypertension, and physically active patients. But here is LDL cholesterol is borderline 190 milligram per deciliter and LP is again in 160. So all these cases are the culprit is LPA. So you have to identify this LPA level for that. We can use partially with lipid to imaging studies also. We can correlate sometimes CSC scan and CT angiography. Our decision in laboratory medicine is equivalent to our lab result, yes or no. So now here are some challenges in our lifestyle because some new technology we are not accepting and new technology training and resources the requirement and if we good training and we are accepting this technology, then we have moved towards the next newer technology. In future trends in is lipidology is a confirm and advanced lipid testing today is not recommended for routine clinical care. However, it is beneficial in certain clinical cases like premenopausal women, family history and premature coronary heart diseases. Weight loss and exercise and LDL reduction of of LDL cholesterol, high level of HDL cholesterol is recommended. And nowadays, initially we are reporting in triglyceride, cholesterol, HDL, LDL and VLDL. Now we are reporting in first reports also non-HDL cholesterol is a target for that, and this test plays a valuable role and just a traditional risk factor of cardiovascular risk. And thank you for your patient hearing. Any question I will give prepared to give the answer. So many students you have.
Good morning. Thank you, sir, for sharing your valuable knowledge and expertise with us. This was This was indeed an insightful and an informative session. We got to know that there is something called as a lipid evaluation rather than lipid profile testing. So this is, and that plays an extremely crucial role in cardiovascular risk assessment. So to know about lipid profile testing beyond just the conventional lipid markers has been really eye-opening. As sir is open for questions, please take this opportunity to gain further clarity and knowledge on this topic.
I think lately, sir, I think a good number of cases that you also showed where there is a new concept of MI in young people that is happening and brought in lipids. And another correlation which commonly people are seeing these days is with COVID. Does COVID have any studies available which suggest modification of lipid profile or the reasoning behind why this is causing an MI in young?
Actually, in international system of teaching, in the vertical teaching, because in biochemistry with physiology, anatomy, medicine, surgery and local area treatment. So our presentation is almost with all these disciplines. So in COVID is a issue because thanks Government of India, I returned back in 15th March 2020 in Vande Bharat mission in India during that period. So during COVID is a sedentary lifestyle because you are gaining weight, and again another issue is the stress, psychological problem, because what to do after that. This confined area is another risk factor. Again, we are not checking our genetic risk factor because we are not doing any test for in our molecular diagnosis or genetic marker, and just like so many females are there, so no are doing in BRCA1 or 2 gene, and theoretically how many are measuring our LPA level? Almost nil or 0 or 1 or 2. So this is the equation we are not seeing. During that period, we are gaining weight, sedentary lifestyle, stress is another factor for this incident. So probably this will be the one of the correlation.
Thank you, sir. Extension of sir's question, are there any studies associating vaccine related to COVID to lipid profile or MI, sir? I have seen few of my friends who are not even reached 40, they have already sustained an MI.
When in 96, 97, I was doing some research in normal value of lipid structure in India, is Bengali population, Gujarati population and other that. After that, we are publishing another research project in statin related post statin and we are fighting statin, non-statin, that time publication or any other mechanism, yes or not. In vaccine is protein. This protein is cholesterol esterase protein transfer. These protein transfer mechanisms sometimes may interact with the formation of small dense LDL more. So, maybe that will be the mechanism, maybe I am not sure, but not publish any data regarding this also. Post COVID MI is more in that case. This is not for this is for vaccine or not, or any other issue or any changes in your body. So, not publish any data so far my knowledge. I checked also that way. Because of this preparation, I have to check so many data like that. So, in that case, I am not getting any correlation between these two.
Sir, as a student, we have very sedentary lifestyle. Also, we eat a lot of junk food, and so not a very healthy life. We play very less, mainly on weekends. So, should we also check for MI and go for regular tests on lipid?
Okay. Before that, you think my first slide, just first slide. We remove all this thing in your life. Just one pictorial photographs are there, na? Shopper stop, Inox, some nice food, trans fat. You remove trans fat from your life and you go for physical activity. If you are student, means why you are sedentary lifestyle? You have a good playground, you have to play, you have to active, avoid smoking and drinking also. That, and if you have a family history positive, if you just like cascade mechanism, you check your family history, then you go for the LPA testing, only one LPA testing, and not routine just like lipid profile test, just like so many are writing the lipid profile test. Instead of lipid profile milligram per deciliter, you go for the lipid particle test. If you are finding the particle, number of particle is the most important for this. That's the only the take home message is the instead of milligram per deciliter, number of particle. So, number of particle is more important for lipid testing, because small, and again in small dense LDL number of particles more means the chances for more MI or cardiovascular diseases.
How many of you eat chocolate cake every day? Almost every day. I have seen somebody. Where is he?
I have a query. You mentioned like extended lipid profiling, like small dense LDL, even oxidized LDL, etc. So since long time is in research, even I had done about the oxidized LDL and read about small dense LDL. So still lab is going for LDL, direct LDL, max to max. So is there like any diagnostic lab like not India, at least abroad also, whether they are testing a small dense LDL or oxidized LDL as diagnostic, like in diagnostic laboratory, not in research laboratory?
In everywhere, mostly performing the direct HDL.
Yes.
Direct HDL number one.
Yes,
Ha.
that.
And this is methodology is detergent based.
Yes.
And in critical cases, most of the countries outside India, even started in India, is I am not sharing the hospital's name, they are implementing the NMR technology. NMR. NMR is replacing this lipid testing and other marker testing. NMR in future.
So by changing methodology, it will be better,
Better,
to
better.
evaluate lipid.
Just like peak. Initially, we are doing a electrophoresis for glycosylated hemoglobin. Now we are going for HPLC. HPLC is the peak. Peak is the ideal for the specific particle. So this will be the better option, better marker for that.
Okay, sir. Thank you, sir.
Any more queries? I guess if you have no more queries, if you want to get clarified later on, sir has provided his email IDs. You can always contact with sir. So I will be happy to help you out.
Another thing is, anybody is interested for exchange program or 6 weeks something in our institute, you are welcome for that. You may apply for that. Thank you. And lastly, I am very much thankful to the organizer giving fantastic hospitality for me. Thank you.
Thank you, sir. Now I like to invite Dr. Vijay Kautilya, sir, Associate Dean Paraclinical, to say a few words about the session.
Hello, good morning everybody. Well, let me first congratulate the team from biochemistry and thank Dr. Krishna Jyoti Goswami sir for such a wonderful and engaging lecture. I think one very important aspect I noticed is the way he connected the biochemical factors with the clinical correlation. Because that is what brings life to the whole talk and makes meaning to what we have studied, and that's something we can take home. And yes, a lot of new concepts which have been brought in, which normally we don't get in the textbooks. Sir, congratulations, wonderful lecture, gained a lot from this, and looking forward for such interactions in future also. Yeah. With that, I think nothing much to say. I really don't want to keep you long from your activities. Thank you.
Thank you, sir, for your kind words. Now we'll move towards felicitation of our of our guest speaker. I'd request Associate Dean sir to please come up on stage. Sir, please. Please, along with Associate Deans, please, I'd request Dr. Sunita Tripathi ma'am, the organizing person behind this, Dr. Kavita ma'am and Dr. Sulekha ma'am to come forward for the felicitation. Before ending the program, today's lecture, I would request Dr. Kavita ma'am to please deliver the vote of thanks.
Good morning, everyone. It is my privilege and honor to deliver the vote of thanks for today's international guest lecture, Beyond the Basics, the Role of Advanced Lipid Testing in Modern Medicine, organized by Department of Biochemistry. On the behalf of Department of Biochemistry and the Institute, I extend my heartfelt gratitude to our esteemed speaker, Dr. Krishna Jyoti Goswami, faculty at Lincoln University College, Malaysia, for sharing his invaluable insights on advanced lipid testing and its implication in modern medicine. Your expertise and engaging discussion has enriched our understanding, and we deeply appreciate the time and effort you have dedicated to this session, sir. I would also like to express my sincere gratitude to our Dean, Dr. G. Pradeep Kumar, and our Associate Deans for their constant encouragement and support in making this academic event possible. Your leadership and vision continue to inspire us in our pursuit of excellence in medical education and research. A special thanks to our administrative team whose meticulous planning and coordination ensured smooth execution of this lecture. Your dedication behind the scenes has played a crucial role in its success. Lastly, I extend my appreciation to all the faculty members, students, and the participants for their enthusiastic engagement. Your curiosity and active participation made this session even more meaningful. Thank you all once again, and looking forward to more such enriching academic discussions in the future. Now, I request all to rise for national anthem. Followed by that, we shall have a group photo with all the students and faculty.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता